Care of patients with disorders of the upper gastrointestinal system. Anorexia is classified as a psychological disorder. Even though it is a psychiatric disorder, the patient can be admitted to the medical floor for treatment of malnutrition by either enteral or parenteral nutrition therapy. Bulimia nervosa is also a psychological disorder. Here, laxatives may be taken to purge the system after binge eating. When it is practiced frequently, it can often lead to severe fluid and electrolyte imbalances, starvation, dental problems, and ultimately death. With obesity, more than 40% of the United States adult population are defined by a body mass index of 30 or above, and this is considered as obese. Known contributors to obesity include high-calorie prepackaged foods that are readily available, high fructose corn syrup that is in foods, soda consumption, high-fat fast foods, as well as supersized portions that are available in restaurants. Roughly 3 million Americans are morbidly obese. This means that they are 100% above their ideal body weight or their BMI index is greater than 40. There are various complications of being obese. One is diabetes mellitus, hypertension, hyperlipidemia, coronary artery disease, obstructive sleep apnea, cholelithiasis, cancer, arthritis with back and or knee problems, as well as the increased susceptibility to infectious diseases and decrease in wound healing. Bariatric surgery may be considered when the BMI is greater than 40, or if the BMI is 35 or greater with one or more of the obesity-related complications. There are long-term problems that can result from the decrease in the amount of food, vitamins, and minerals that are able to be absorbed. The RYGB patients are also at risk for dumping syndrome. Dumping syndrome results in nausea, weakness, sweating, and diarrhea that occurs after meals. The individuals that have the Roux-en-Y banding procedure are at most susceptibility for having disorders due to their restrictions placed on their eating capacity. The types of surgeries are the biliopancreatic diversion with the duodenal switch or the gastric bypass, as well as the Roux-en-Y gastric bypass or the vertical banded gastroplasty. The total gastric bypass procedures of the Roux-en-Y causes severe nutritional deficiencies, and it is no longer recommended. The Roux-en-Y gastric bypass procedure limits the stomach size, as well as the duodenum and part of the jejunum are bypassed. This limits the absorption of the calorie intake. Laparoscopic banding, with the option of a reservoir band and subcutaneous access to restrict the stomach further, after compensatory expansion has occurred. With the Roux-en-Y procedure, there is danger of leakage of stomach contents into the abdomen in the early postoperative period. Later, gastric stretching may cause the staple line to break and a leak to occur. Signs and symptoms of this are tachycardia, dyspnea, or restlessness. An upper GI series or CT scan can diagnose the problem. The band in the vertical banding procedure may erode into the stomach over time and cause leakage. The Roux-en-Y patients are also at risk for dumping syndrome. Dumping syndrome results in nausea, weakness, sweating, and diarrhea. These symptoms tend to occur after meals that include concentrated sweets. This is why the Roux-en-Y patients are advised to avoid refined sugars. Other complications of the Roux-en-Y surgery may occur in the respiratory and the cardiovascular system. About 1/3 of the patients that undergo bariatric surgery will develop gallstones. Ursodeoxycholic acid therapy can be used to treat the gallstones, although poor compliance and cost are issues for this therapy for many patients. All bariatric surgery patients are at risk of nutritional deficiencies. Those with the Roux-en-Y procedure are most likely to develop deficiencies of iron, vitamin B12, calcium, and folate. Supplements must be taken for life for these individuals. Causes of stomatitis can include trauma from ill-fitting dentures or malocclusions of the teeth, poor oral hygiene, as well as nutritional deficiencies. Excessive smoking, excessive alcohol, pathogenic microorganisms, radiation therapy, and medications are other contributors to stomatitis. Dysphagia means difficulty in swallowing. It is the most common symptom of disorders of the esophagus. A modified barium swallow test may be ordered to determine the specific cause. A video fluoroscopy is used during the test to visualize the swallowing process. The mnemonic rule, RULE, identifies the need for further testing. Rule indicates R is red, U is ulcerated, L is lump, and E is extending for 3 or more weeks. Acid reflux has replaced tobacco and alcohol as a primary irritant, leading to adenocarcinoma of the esophagus. Gastroesophageal reflux disease, or GERD, is a cause of Barrett's esophagus, which is a precancerous condition. Hiatal hernia is a result of a defect in the wall of the diaphragm where the esophagus passes through. This will create a protrusion of part of the stomach or the lower part of the esophagus up and into the thoracic cavity. A hiatal hernia is diagnosed by an upper GI series. The patient will be instructed not to eat within 3 hours of going to bed. The intake of alcohol, chocolate, caffeine, and fatty foods should be limited. Smoking should be avoided. The ingestion of fats relaxes the sphincter, thus allowing the reflux. Gastroesophageal reflux disease is a syndrome and not a disease process. 90% of patients with GERD have a hiatal hernia. It is caused by transient relaxation of the lower esophageal sphincter. The relaxation allows fluids or food to reflux into the esophagus from the stomach. Heartburn or dyspepsia and reflux are the most common symptoms of GERD. Patients who are prescribed long-term use of proton pump inhibitors are at risk for nutrient malabsorption, especially magnesium, calcium, and vitamin B12. Irritation results when the stomach contents containing hydrochloric acid, pepsin, and other enzymes are refluxed into the esophagus. Gastroenteritis is inflammation of the stomach and the small intestine. The patient with gastroenteritis should be kept NPO until vomiting has ceased. Once tolerated, fluids containing glucose and electrolytes should be started. Examples would be Pedialyte or Gatorade. The main cause of chronic gastritis is H. pylori bacteria. Gastritis is an acute or chronic inflammation of the mucous membrane lining the stomach that causes changes in the tissue. The main symptoms of gastritis are anorexia, nausea, vomiting, pain and tenderness in the stomach region, hiccups, and sometimes diarrhea. The image shows a gastric peptic ulcer in A and a duodenal peptic ulcer in B. H. pylori infection with the use of NSAIDs for pain is a major cause of peptic ulcer. Stress does have some play on the progression of peptic ulcer. Tension, anxiety, and prolonged stress do alter gastric functioning. Prolonged physiologic stress produces what is also known as physiologic stress ulcer. Drug-induced ulcers are most commonly caused by aspirin, NSAIDs, biphosphonates, alcohol, and glucocorticoids. The upper GI mucosa can resist corrosion. All the areas that are exposed to hydrochloric acid and pepsin in the gastric juices have an ample supply of mucus glands that secrete protective alkaline mucus. Ulcers develop when the mucosa cannot protect itself from the corrosive substances. A peptic ulcer is an ulceration with the loss of tissue in the upper GI tract. The term includes both the duodenal and the gastric ulcers. Signs of acute GI bleeding will include complaints of weakness and feeling faint, nausea and vomiting, restlessness, thirst and mental confusion, hematemesis, which is vomiting of bright red blood. Blood that has been sitting with gastric juices looks like coffee grounds. Black stools always indicate the presence of digested blood. This indicates that the source of the bleeding is in the upper GI tract. A peptic ulcer is diagnosed by endoscopy, which can locate the site of ulceration and bleeding. This also allows for differentiation between benign and malignant ulcerations and between the esophageal ulcer and a diverticulum. Eliminating H. pylori with antibiotics is the first-line treatment, and the gastric acids are reduced with proton pump inhibitors. NSAIDs and other substances that are known to damage the stomach mucosa are eliminated. There are three major complications of peptic ulcers, which are hemorrhage, perforation, and obstruction. Gastric cancer is diagnosed by an upper GI series. and an endoscopic examination of the stomach with a biopsy. There are types of tubes that are used for enteral feedings. There is a nasogastric tube, which is passed from the nose into the stomach, a weighted nasoduodenal or nasal jejunal tube. This is passed through the nose and into the duodenum or the jejunum. For GI decompression, abdominal distension with increased pressure within the abdominal cavity is very uncomfortable for the patient. Excessive fluids and gases also interfere with the expansion of the lungs by pushing up on the diaphragm and with normal function of other nearby organs. An NG tube to remove fluids and gas from the stomach may be inserted, but applying too much suction can pull the gastric mucosa into the drainage openings or the eyes of the tube, and this can cause damage to the mucosa and traumatic ulceration. Unless it is ordered otherwise, the nurse should use low-setting suction, which is 80 to 100 millimeters of mercury. The Levine tube and the gastric sump tube are shorter because they are only intended to reach in as far as the stomach. For enteral nutrition, if a patient has long-term difficulty taking in food orally, for example, they may be in a coma or may have dysphagia from a stroke, that is when enteral feeding is indicated. An NG tube or nasoduodenal tube will routinely be initiated. If long-term therapy is needed, then a gastrostomy tube or a G tube will be placed. The placement is in the duodenum is confirmed by an X-ray film before the feedings are started. The feedings can be given at specified times throughout the day or on a continuous basis. If the feedings are ordered as continuous, they should be administered with a feeding pump. A PEG tube or percutaneous endoscopic gastrostomy tube is a feeding gastrostomy tube that is placed endoscopically through the abdominal wall and into the stomach. For peripheral parenteral nutrition, if a patient can swallow and eat, but they're not able to take in adequate nourishment to meet the body's requirements, then peripheral parenteral nutrition, or PPN, may be given to supplement the diet. The glucose content in PPN is no greater than 10%, which this is not enough to supply the caloric needs of the body. Protein in the form of amino acids, vitamins, and trace minerals may be supplemented. For total parenteral nutrition, or TPN, this is indicated when the patient cannot ingest or digest foods normally or has a problem with malabsorption. TPN is essentially a form of IV feeding. TPN is total nutrition, and patients can be maintained on IV therapy for nutrition as long as necessary. A long-term central catheter, such as a PICC line or an implanted port, will be placed into a large central vein. Day-to-day care for TPN patients includes monitoring vital signs, glucose levels, and fluid and electrolyte balances. The patient is weighed daily and frequent mouth care is provided. The rate of TPN is slowly decreased to gradually lower the dextrose load before the TPN is discontinued. Dumping syndrome. Some patients who have had a gastrectomy or who are started on full-strength tube feedings experience a complication known as dumping syndrome. This is caused by a rapid passage of large amounts of foods, especially sugars and liquids, into the jejunum. The patient with dumping syndrome should be taught to avoid eating large meals and to minimize fluids during the meal.